Dear colleagues and friends, in order to spare time, we are more or less not bad with the time, but nevertheless, let's continue. Sorry about missing my presentation, but you saw the case was quite challenging. Hopefully, you have understood, in fact, the difficulty of the case. The difficulty of the case was consisting mainly in that the stent graft, the aortic stent graft, момчета, можем ли да пуснем финалната картинка от това, което се разбрахме с доцент Станков So we will try now to show the final projection after I left the cath lab. Everything finished very well. The patient is in a good condition, absolutely hemodynamically stable. The puncture places are absolutely normal. And in fact, the problem is that the stent graft is inside an aneurysm. With dissection, it's easy, because in dissection, the ostium of the arteries to be punctured are very close to the tissue of the stent graft. But when the stent graft is inside the aneurysm, in fact, with the catheter, retrograde catheter from the carotid, the tip of the catheter, in fact, is not touching directly the tissue of the graft, but it's somewhere in the aneurysm. So, in fact, we have to find the graft with the steering the catheter. And this is the final injection, showing not only the puncture site, not only the puncture site of the axial artery. I mentioned yesterday that it's better. It's okay. Thank you. I mentioned yesterday that to puncture the subclavian artery is not a good idea, because the subclavian artery is inside the chest and the axillary artery is outside of the chest. So in case the closure device is not successful, obviously in this case it is successful, we have used a suture-based closure device, ProGlide, and definitely there is zero residual bleeding. Probably here there is slightly point, you see, it's a very small point of probably contrast going outside, but we see here not only the puncture site, but also the flow into the bridging stent and the brachiocephalic trunk. You see there is no leakage. In fact, the aneurysm is not filled anymore by the brachiocephalic, and it was absolutely connected. And the beauty is there is no filling from the subclavian, because the subclavian was directly arising from the aneurysm. And you see that with the late filling of the left vertebral, this is definitely the Steele syndrome. The body of the patient is utilizing the Steele syndrome to supply the left subclavian. And that's it. In fact, the patient is treated definitely. He doesn't need any more anything. We have commented with Donald Reed in the panel that on a second stage we can do with the subclavian artery everything. We can put coil, we can fenestrate, we can do carotid to subclavian bypass, we can do everything, but at the context of the clinical case, the case is done. And I mentioned we probably, during the last 10 years, I think we have around 900 aortic cases, and we have covered probably at least 300 left subclavian arteries without any clinical problem. So in case there is an equipoise between the vertebral arteries, in case the two vertebral arteries are good enough by size, and they have a good communication on the level of the basilar artery, there is no problem with the subclavian artery. So this is the final injection of the case, and we can proceed now with a similar topic. And in fact, this is the topic of in situ fenestration. Давайте с презентацията. In situ fenestration for aortic arch pathology. Mainly dissection, of course. I have nothing to disclose regarding this topic. So, Aortic dissection, you know very well, it's one of the most deadly disease in the medicine. And unfortunately, despite all the surgical hybrid techniques, advancement of endovascular therapy and so on, there is a quite still high mortality. And the type A aortic dissections are definitely a huge challenge, not only during the acute period, but also during the subacute and chronic period, mainly because of the need for secondary procedures. You know very well that the complex intervention, surgical intervention, is including not only the ascending aorta, but also partial or total arch replacement, so reimplantation of the brachiocephalic vessels. But in very complex cases, the majority of the surgeons, they prefer to save the patient life, to secure the most proximal entry point, and to finish the operation with the patient's life already saved. It's true, but in fact, the patients with saved life, the proximal treatment is not sufficient in more than 30% of the cases to isolate the false lumen, because there are secondary and tertiary entry points, tears, that continue to fill the false lumen. And in fact, the patient is not treated completely, because with the late growth of the false lumen and compression of the true lumen, the malperfusion syndrome can be, and it is, the second leading cause of death. So in this situation, at least 15%, even more, 20% of the cases, these patients need secondary procedure. In case the procedure is surgical, the surgical risk is enormous. The mortality, morbidity in clinics like Mayo Clinic, these are the data from Mayo Clinic, the mortality is between 9 and 15%, and also the stroke rate is about 5 to 7%. So because of that, the pioneers of this surgery, Denton Cooley and Michael DeBakey, they did a lot about the hybrid approach, the branching and so on, but the new era is definitely for aortic dissection, not only type B, but also during the last several years for type A dissection. Nikolai Volodos was the pioneer. This Ukrainian vascular surgeon was the first one to make custom-made, homemade, in fact homemade, stent graft that was sewed onto Palmat stent in both edges. And for this false aneurysm, thoracic false aneurysm, he in fact isolated, it's after car accident, he isolated the false aneurysm with the implantation of this homemade stent graft. You see the false aneurysm on the bottom image is not already seen. And in fact, the experience with an endovascular treatment is growing, and the data are showing that it's better to utilize for secondary procedures, not surgical, but endovascular approach, and it's written in the guideline. It's written in the surgical guideline. This is the surgical guideline. The surgical guideline is telling us that endovascular stenting instead of surgery if anatomy is suitable. What does it mean, anatomy suitable? The Ishimaru classification doesn't pay any attention about type A and type B. Why? Because the leading discrimination is the landing zone. It depends where is the landing zone for stent graft, aortic stent graft implantation. And all the procedures, arch procedures that require landing zone in zone 0 and zone 1 will require special techniques for cerebral vessel inflow provision, because this landing zone is this segment is covering the carotid, the left carotid or the brachiocephalic trunk. And there are several options to provide possibilities for stent graft implantation, aortic, hybrid approach, surgical carotid to carotid bypass, debranching and so on. But unfortunately, all these possibilities are requiring at least partial chest opening. So in fact, it's surgery, it's not endovascular. The totally endovascular options are fenestrated grafts, like shown in this fenestrated grafts, or chimney or branched grafts. The problem with these devices are because that they are very expensive. You probably remember yesterday Frank Criado mentioned that in some patients in US, only for grafts and implants, the price is $70,000 with the Gore device. The Gore device is one of the probably the best branched graft on the market, but it's extremely unfortunately expensive and not readily available, because the anatomy is so versatile that we have to have on the shelf 20 grafts. We have to have 5 million in grafts on the shelf in order to correspond to the anatomy. And because of that, totally endovascular options are a good idea. Totally endovascular, not surgical. They are in our local practice. There are 3 options: large size aortic bare stent implantation in the arch across the vessels, brachiocephalic vessels chimney assisted TEVR implantation, or arch TEVR across the brachiocephalic vessels, and in situ fenestration, what we just have done during the live case. And this is our experience. You see almost 900 patients performed during the last 10 years for aortic dissection and aneurysm. This is a case, we published this case of, it was a bailout, critical condition, young gentleman with extreme compression of the true lumen. You see on the CT, you see on the CT that there is extreme compression. This is the true lumen. You see, this residual true lumen is practically almost totally obliterated because of the huge false lumen. And in this particular case, what we have done, the patient was really in a critical condition. Добре. Извинявайте. The patient was really in critical condition, and probably it's loading. Yes, because it's loading a little, it's big file. And we have implanted, you see the multi-layer flow modulation. It's a multiple layers stent. We have implanted from the coronaries through all the brachiocephalic vessels, all the way down to the renal artery. This is the anatomical situation. And the beauty is that between the 6th and the 12th month, the false lumen into the ascending aorta disappeared, because in fact the flow was centralized in the true lumen, and the false lumen was more or less isolated on the level of the stented segment. And this is in fact the 5 years follow-up. Пробвайте да го плейвате вие, защото като натисна, скача на следващия слайд. Да. Yeah, okay, excellent. Thank you so much. You see how was the dissection on the left side and how was the flow after 7 years after the patient is doing very well. What about chimneys? It's possible, but not always. It's possible, not always. In the chimney situation, we have to implant parallel to aortic graft chimneys, but to implant chimneys, we have to pay attention to the oversizing of the aortic graft. So the aortic graft has to be very much oversized in order to accommodate the invaginations for the chimneys, because otherwise there will be endoleak, like Dr. Adam mentioned yesterday. The gutters are one of the main problem about this technique. There are multiple publications, The chimney is a very good technique with promising result. For example, this meta-analysis is showing that the results are acceptable, better than the surgical at least. And we have, in our experience, 18 patients during the last already 5 years. 4 patients with 3 chimneys, 7 patients with 2, and 7 patients with 1 chimney. With a very good mortality rate was only 5%, you see, in hospital. Procedural mortality was 0, but unfortunately 1 patient died during the hospital stay. 57-year-old male, he was operated for type A aortic dissection 6 months before the procedure. and for type A aortic dissection with implantation of surgical graft. Unfortunately, he had huge expansion of the false lumen, and unfortunately, he had a secondary entry just before the brachiocephalic trunk. So it's still type A aortic dissection. So in fact, the patient is not treated completely. So we have done direct retrograde carotid puncture close by the proglide, like in today's case. And this is the final picture of the place of the puncture of the carotid. We implanted through the carotid one of the chimneys, and through the axillar, right axillar, the other chimney. And parallel to the chimneys, we have used the surgical aortic graft as a landing zone for the chimneys and for the aortic graft. So they meet each other inside the surgical graft, parallel to each other. So this is the situation after the implantation of the chimneys and the aortic graft, and probably this is the final result, but I will ask the guys. Давайте следващия слайд, пак пробвайте да го плейнете отдолу. Yes. Unfortunately, yeah, it doesn't play. In my laptop, it was playing without any problem. Okay, believe me, it was a very good result. And this is, in fact, the control CT showing that they are patent all the chimneys, all the brachiocephalic vessels, and in fact, it's a completely isolated false lumen. This is in situ fenestration. There are multiple small series, in fact, similar to our experience. We have nowadays 14 patients already. During that presentation were 13, and today's case was the 15th one. So we have already 15 patients, 5 with 1 fenestration, 6 with 2, and 2 patients with 3 fenestrations. What is the protocol? Probably one of the most important part of the protocol is that we are reversing the flow from the femoral artery, big sheet, 8 French sheet. We are reversing the flow from the femoral to the carotids with 2 tubing on Y shape, splitting the flow into the carotids after the implantation of the stent graft, because the stent graft is covering and stopping the flow to the brain, and because of that, following the gradient, the natural gradient from femoral to carotid, the flow is going up. So it's a retrograde flow from the femoral to the, and after the implantation of the stent graft, we have to puncture from the left carotid retrograde. This is nice. See how the blood is coming from the femoral. You see, coming from the femoral, and it's going up to the sheet that is positioned into the brachial artery of the subclavian, connected to the subclavian. And in fact, this is the pressure into the carotid and the systemic that is showing around 70%, like we have shown today. Around 70% of the systemic pressure we have providing with this retrograde bypass. Okay. After position of the stent graft, we are using 2 techniques like I have shown, and these 2 techniques are all electrified wire to puncture the tissue of the graft, or like mentioned, and we are cutting for some wires in order to be even more aggressive. We are cutting the 2 final centimeters, the floppy part, in order the wire to be really puncturing. It's like needle. And we are using this needle, electrified needle, in order to puncture. And this is one patient operated, I think, 3 months ago, yes, before the procedure, with Bentel. You know, it's a reimplantation of the coronary arteries with bypass and aortic valve replacement for type A aortic dissection. And unfortunately, again, you see the false and the true lumen. The false lumen is bigger, and there is an entry point just above the surgical graft. So here is the surgical graft. Here is the surgical graft, and here is the entry point of the dissection. In fact, this is The operative mortality is huge. It's the probability of the patient to die is probably more than 30% during a secondary surgical procedure. And this is what I'm showing here. This is the opening of the aortic graft. And the position, you see there is the position of the 3 catheters from the subclavian, left subclavian, from the axillar, and from the carotid. And this is hopefully, go next please, you, in order to be next. And you are going to see how the wire is penetrating and is going to the lasso. So this is the wire, I'm circled there, the wire to see, David, next, no, go next. And after the wire is penetrating, the lasso, the snare, is waiting below. This is the snare, and you are going to see now how is the wire coming and entering the snare. Давай, next please, следващия. Опитайте се да го плейвате, или го, оставете го малко, може би ще се зареди, защото the presentation is too big. Yeah, you see how the snare is catching the wire, and in fact on such a way we providing true and true approach from the carotid and from the femoral. So we have one and the same wire from the carotid and from the femoral. So this is the true and true. And we have control of the wire on both sides. And we can implant on this externalized wire, we can implant everything, but of course we have to penetrate the tissue of the graft. And because of that, after the penetration, we are going 1.5 millimeter, 2 millimeter, 4 millimeter, 5 millimeter, 6 millimeter, and after the 6 millimeter opening of the fenestration, we are implanting the bridging stent graft. In this particular case, this is the big graft, 10 by 57. And we have performed the same in the 3 for the 3 vessels. Пробуйте да го плейвате вие. This is probably the final result. And you see the 3 bridging grafts going into the brachiocephalic vessels with excellent result. Next, давайте следващия. Okay, the clinical case evolution, it was very good. Next. And I think this is coming the last slide. Okay. No. It's very interesting case now. Next. This is the follow-up of the previous case. Go next. There was a young lady after car accident, next, with a huge aneurysm at the final part of the aortic arch. Next, this is a 34-year-old lady. You see the metallic synthesis of the pelvis and the articulations there. Next, she was in a very difficult, very bad condition after and this is the aneurysm. This is a huge aneurysm at the distal part of the aortic arch. Next. And huge proximity of the aneurysm to the left carotid. And this is retrograde puncture of the left carotid. Next. And after making the fenestration, next, this is in fact the positioning of the stent, aortic stent graft with coverage of the left carotid. Next, and in this particular case, by the left carotid, we put a chimney. This is a chimney, so opening slightly the struts of the aortic graft, and the subclavian we did fenestration. It's utilization of combination of the 2 techniques, one chimney and one in situ fenestration. Next, and of course, all these implantations are done under rapid pacing in order to stabilize the position, not to allow the flow to push the aortic stent back. And this is the penetration. You see how, like a needle, the wire is penetrating the tissue of the graft. Next. And the snare is catching the wire. We catch the wire, not the snare. Okay, and this is catching the wire by the lasso. Next. And you can see there is no intubation, so it was a conscious sedation procedure. Next, and after the true and true approach and balloon dilation, everything is done on the same way. Next. And we did next. And this is probably this is the final result. Finally, one picture of final result. You see the chimney and the fenestration are absolutely excellent, and the aneurysm disappeared. There is no more aneurysm there. It was on the level of the subclavian. Next, and 3 days later on discharge we did, and this is the final injection to the manta to see that the manta closure is sufficient. Next, and on discharge we performed control CT showing, next, control CT showing quite good result with the aneurysm totally isolated. Next. Okay, as a conclusion, despite endovascular and surgical advancements in techniques, the aortic arch pathology is quite a big challenge to be treated. And because of that, we are waiting with open eyes all the next technology to facilitate our life as interventionalists and the prognosis of the patients in this scenario. Thank you very much for your attention. Comments? Questions? Everything clear.